are new to ECHO, this is a model that builds virtual communities of practice and learning. Sessions begin with a didactic presentation, followed by de-identified case-based learning, and group discussion to foster deep knowledge and build individual capacity. If you selected to receive continuing education credits in your registration, we will follow up by email with instructions of completing the post-session evaluation and attending all credits. So the ECHO is an all teach, all learn supportive model, and it thrives on the interaction of the full learning network that's on the call today. So we encourage you all to participate in the conversation today. I'm going to ask that our wonderful hub team that's on the call today to unmute, introduce themselves by name and where they're from. So Dr. Chawla, would you like to begin?
Sure. Thank you, Cassie. I'm Suman Chawla, and I serve as the Associate Dean for UT Dental School's Advanced Education Programs, and I serve as the PI for this postdoctoral grant that supports the ECHO, DENT ECHO. Thank you for joining us today.
Wonderful. Thank you. Magda.
Hi, everyone. I am Magda de la Torre. I am coordinating the DENT ECHO program, and I'm looking forward to our future sessions, and welcome.
Wonderful. Thank you. Dr. Stokley.
Hi, I'm Dr. Rhonda Stokley, and I am the state's Public Health Dental Director. I'm located at the Texas Department of State Health Services in Austin, and I'm very excited to be here and participating in this ECHO.
Thank you. Dr. Franklin.
Good morning. My name is Dr. Franklin, and I am a public health resident with UT Health San Antonio, the County Health Department in Mobile, Alabama.
Great. Thank you so much for joining us today. Dr. Aguilera.
Hi, I'm Dr. Rosalie Aguilar, and I'm with UT Health San Antonio School of Dentistry. I'm a project coordinator here.
Thank you so much. And Dr. Marwa.
Hi, I'm Dr. Rutisha Marwaha, and I am a faculty at the Department of Comprehensive Dentistry. Welcome, everyone.
Good, great, thank you. And again, I want to welcome everyone on the call today. It would be wonderful if you put your information in the chat so we can dialogue with each other, network, put in your name, affiliation, and your email. As I mentioned, this is a all teach, all learn community, so we want to make sure that we are all involved in the conversation today. Our session today will include a didactic presentation from Dr. Stokley on dental care of the pregnant woman. Is it safe and smart? So why aren't we doing it? And a case presentation from Dr. Franklin, who is in Mobile, Alabama. So Dr. Stokley, when you are ready, please go ahead and start with your presentation.
All right. All right, can you see my screen?
We want to put it in there we go. Perfect.
Okay. All right, actually let me move it real quick. Y'all bear with me, technical difficulties. I'm gonna move it over here where my microphone is so I'm not looking over there the entire time I'm talking to you. That might go a little better. All right, here we go. So again, the title of my presentation is Dental Care for Pregnant Women is Safe and Smart.
Oh, sorry, Dr. Stokley. We can only see your desktop with all your items on it. We don't see the presentation at the moment.
That's so strange. And we went through this the other day. It all worked just fine. Okay, so I'll look over at you as I'm able, because I'm not reading straight off the slides. All right. Here we go. We got it. All right. So dental care for pregnant women is safe and smart. So why aren't we doing it? Some of the things I'm going to cover today is why does oral health for pregnant women matter? Concerns about treating pregnant women that we may have. What is safe to do and says who? Information about the oral health of pregnant women in Texas. And what do we do and what should we do? So first, why does it really matter, right? Pregnancy is just this little narrow point of time in a woman's life. Why can't you just put things off until later? Well, for one of those reasons is, pregnancy wreaks havoc on a woman's body, right? Well, the mouth is included in that. There can be pregnancy-related gingivitis, tooth erosion from severe morning sickness and GERD, pregnancy granulomas, tooth mobility, just like the other ligaments in our body loosen to get ready for child delivery, the ligaments holding the teeth can get loose as well. So some women really do experience tooth mobility. And then, of course, there's whatever dental problems they carried with them prior to pregnancy, any dental caries and periodontal disease. Oral health for pregnant women is important for baby because there's associations between maternal periodontal disease and preterm births and low birth weight babies. Doesn't mean it causes it, but there's associations between the two. There's also vertical transmission of caries causing bacteria from mother to child. So if mom's got a mouthful of disease causing bacteria and then does those typical mom things, right? Kisses baby, may taste baby's food to make sure it's not too hot, and then feeds baby with the same spoon. All those common mom things can pass along those disease-causing bacteria to baby. It's also important because it's a teachable moment during pregnancy for a woman to care about her own health and improve her own health, which will in turn improve baby's oral health. And it's an opportunity for her to learn and think about baby's oral health. So why do we hesitate to treat pregnant women? And the honest answer is pregnant women are scary, right? I mean, it can feel kind of scary treating them because there's a baby in there. And that can make us feel uncertain and hesitant because, goodness, we don't want to do anything to cause any harm. And I don't know about y'all, but basically my takeaway from when I was in dental school was that, you kind of keep a pregnant woman at arm's length. I mean, if there's something that's a dire emergency, sure, you treat that. But if there's anything else that she needs that can wait a few more months until after delivery, that's kind of what we were taught to do, basically. We've learned a lot since then with research. But another concern is liability, right? I mean, pregnant women do have miscarriages. They have babies that are born with significant problems. And we don't want to be connected with that, right? As they're looking back on maybe what happened over the course of that pregnancy. Well, I did get 2 fillings and a root canal while I was there, and that can be concerning for us. Funny enough, we're scary to them too. In a survey of pregnant women called the Pregnancy Risk Assessment Monitoring System, or PRAMS, they survey pregnant women every year in Texas. And this is a combination of 2016 and 2017 data. They asked pregnant women if they thought it was safe to go see the dentist during their most recent pregnancy. 18% said they did not think it was safe to go. And when we break that out by race and ethnicity, more white women thought it was okay to go, but look, 22% of Hispanic women didn't think it was safe to go see the dentist while they were pregnant. And for 2017 total, only 1/3 of pregnant women saw a dentist even to have their teeth cleaned during their most recent pregnancy. So just 1/3 of women were seen. When we look at this by race and ethnicity, 40% of white women went and got their teeth cleaned, so not even half for white women. Black women only 23%, and Hispanic women only 29%. But look, a lot of the women had coverage. When asked if they had insurance coverage for dental care during their pregnancy, 63% of women overall said that they did. So they had the coverage to go do it and just weren't doing it. But that dipped significantly with Hispanic women, who only about 54% had coverage. But still, over half had coverage, but yet overall only 1/3 of pregnant women actually went. So we were realizing in some of our earlier work that, we were really working to get pregnant women to schedule appointments with the dentist, and we were hearing back from them that the dentist didn't want to see them, didn't want to treat pregnant women, or, oh, just come back after you've delivered. So that led us to realize we need to find out how dentists overall are feeling about this. So back in 2018, we conducted a survey where we emailed almost 15,000 licensed dentists in Texas to ask how they felt about these topics. And we got almost 1,600 responses. When asked about the percent who agree with the safety of treating pregnant women at any point during pregnancy, and in that question, I mean, we were clear. That means x-rays, it means local anesthetic, fillings, dental treatment, how they feel about that at any point during pregnancy. 35% somewhat agreed that it was safe anytime. Almost 17% strongly agreed. But look at the right half of this graph. Over 40% are over here on this side saying they somewhat disagree or strongly disagree that it's safe to provide dental treatment at any point during pregnancy. So there's a lot of dentists feeling very iffy about doing this. But dental care is safe and smart for pregnant women. But says who? It's one thing to just say, go do that, but who's really the ones saying that this is okay to do? And it's big groups. ACOG, the American College of Obstetricians and Gynecologists, that's the preeminent group for OBGYNs, had a committee opinion focusing on oral health. They're telling their members, reassure patients that they can get x-rays, just shield the abdomen and the thyroid. They can get local anesthetic with or without epinephrine, and it's safe during pregnancy. They also say, looking at this second bullet here, that you can get your extractions, root canals, restorations, amalgam or composite. All of this can be managed at any time during pregnancy, and delaying treatment can result in more complex problems. On our side of the house, the American Dental Association strongly supports dental care during pregnancy. They say regular and emergency dental care, including local anesthetics and radiographs, is safe at any stage during pregnancy. So here's something that you can lean on and refer back to, these practice guidances. Here on the left is the National Consensus Statement. And I think Magda said that everyone in attendance is going to be receiving that, and she's nodding. So yes, everybody's going to receive a copy of this. And it's also available in electronic format. I'll have the link for that a couple slides from now. But this statement, this was the result of a big group of people who met experts back in 2012, looking at all this research about pregnant women getting dental care. And with this huge body of research, they said, it's safe. It's safe at any stage of pregnancy. And so the result was this consensus statement. And it was signed off on by ACOG, the American Dental Association, and a ton of other medical, pediatric, and dental groups. The who's who, if you will, of these expert fields agrees on the information in this statement. And it's got some great information in it, and we'll go into some of that in just a second. Here on the right is what the Department of State Health Services has developed, our practice guidance for prenatal and dental providers. It builds off this information in the National Consensus Statement. We've also got some clinical photos in there, which is especially helpful for prenatal providers to kind of see what, a pyogenic granuloma might look like, or some of these other things they may encounter with their pregnant patients. And it really focuses with the prenatal providers on, you need to think about this, you need to ask patients about it, you need to refer. And on the dental half of it, it's the reassurances it's safe, these are the types of medications you can prescribe, and you should treat pregnant women. So in both of these guides, there's pharmacological cheat sheets that tell you what's safe and what you should use with caution. I'm going to go into the one on the left because this is the one in the guide you're going to receive today. The one on the right is what we have in our guidance. But this is something that you should take time to read when you receive it, but just in case you're human and maybe don't get around to it, we're going to go through it a little bit right now. So, analgesics, acetaminophen is in here. Everything in the green on this chart is okay during pregnancy. And it's not restricting this trimester, that trimester. It is safe to be used during pregnancy. And you'll see that even acetaminophen with codeine, hydrocodone, oxycodone, all of these are safe during pregnancy. The only caution it gives is the same caution you use with any patient. Shortest duration, don't give refills, those same things, because you don't want to risk them developing a dependency. Aspirin, ibuprofen, naproxen, those can be used in short duration, 48 to 72 hours. Avoid in the first and third trimesters. So there's times you can give it. But if even just seeing that makes you think, oh, I don't want to think about first and third trimesters, you've got a lot of pain relief options in this green part of the table. Antibiotics. All the stuff we typically give is in the green category, may be used during pregnancy. Amoxicillin, cephalosporins, clindamycin, metronidazole, penicillin. All of those are fine. There's some to avoid, clarithromycin and others. And the one that you never use during pregnancy is tetracycline. Anesthetics. Do you know that you could actually do IV sedation or general anesthesia? They recommend limits on how long you do it and in the third trimester, and of course want you to talk to the prenatal provider. But that's not going to apply to most of you in the audience, but just for background so that you're aware of that. Now the stuff we typically do are local anesthetics with and without epinephrine are on this green row here, may be used during pregnancy, no restrictions on which trimester the woman is in. And did you know that even nitrous can be used? I mean, I know I learned back in school that like you maybe didn't even want to have nitrous in the room next door going when there's a pregnant woman in there. Nitrous is safe. You need to use less because it's easier to sedate a pregnant woman. But if you feel clinically there is a need that a woman would benefit from having nitrous for their treatment, it's something you can do. Run it by their prenatal provider first, but it's definitely something that's doable. Antimicrobials, pregnant women can have chlorhexidine, they can have xylitol, those things are fine. Just want to avoid alcohol-based ones. So resources, again, that purple guide, the one you're going to get, it's available from the National Maternal and Child Oral Health Resource Center out of Georgetown. You can Google them. Here's the link to actually get the consensus statement. But they've got all kinds of information for providers, information that you could print out or email out to patients if you wanted to. Our site, our program that focuses on this population is called Smiles for Moms and Babies. And so here's the link to our guidance. And we've got a lot of information in there too. So I would say go check it out, wander around and see what you like. You can email us. We've got all this available digitally, but you can email us for hard copies for things like this poster that says, pregnant? Do your gums bleed when you brush? Visit a dentist. It's safe and smart. That could be something if you wanted to hand out to prenatal providers in your immediate area. There's things that you can give them to increase their awareness. So in conclusion, the take-home message, dental care for pregnant women, it's safe, important, and recommended. Don't postpone it. You know, we learned things back in dental school, but that was a long time ago now. There's new research, we know more, and pregnant women should receive dental care. So that's it for me. I really appreciate you listening, and when it's Q&A time, I will do my best to answer any questions that you have.
Thank you, Dr. Stokley. That was really a great information. Is there any questions from the learning community for Dr. Stokley today? If you're a little shy, you can put them in the chat. I do have a question in regards to your slide on the disparity of minority groups getting educated and understanding the importance of dental care during pregnancy. Is there some kind of campaign or information that you might tailor to the community, or how do you address that disparity there? Or what is it?
One thing, well, outreach to communities that have a lot of Black and Hispanic women. One thing that our program is doing is we really work with home visiting programs and parent educators, and a lot of these groups target Black and Hispanic women. And so that's one thing we're trying to get directly to those populations to help them understand that it's safe and that they should go.
Very good. Any other comments, or anyone else that might be, how they are addressing, educating their patients, their pregnant patients? Go ahead, Magda.
I have a question. Dr. Stokley, how can we get our patients to feel safe and comfortable? And not just the providers, us as providers, but our patients to feel comfortable to be seen when they're pregnant?
Part of it, I think, is us feeling comfortable. Like in vaccine talk, we talk about making a strong recommendation, right? You don't sound iffy, you don't sound, uncertain. This might be something you want to do. And I think we can take that same approach with talking to pregnant women about dental care. Be confident when you say it. I assure you this is safe. I've read a lot of research. I'm very up on this, and I'm very aware this is something you should do. It's the right thing for you, and it's going to be good for baby too. And when you say that with conviction, I think that can go a long way, because we're really a trusted profession. But if they pick up from us that we're a little hesitant about it, they'll pick up on that. And there's also information you could give them. I mean, if someone's really hesitant, you could send them a copy of the consensus statement, so they could, not that they want to read it from cover to cover, but just see that all these major people are saying that it's okay. And something like that can give reassurance too. Okay, it's not just my dentist. There's lots of people out there saying that it's okay.
Hi, Dr. Stokley. This is Dr. Tran. Nice to see you here. Thank you for the great presentation. Just to, I guess, kind of piggyback off that question about us being comfortable, is there any way in terms of, I guess, liability, like if anything happens to the pregnant woman, is there any way to protect ourselves from being liable? And, they say like, like what you did caused this to happen during my pregnancy. I don't know. Is there any way to do that, to protect ourselves in terms of liability?
So first off, I am not a lawyer, and this is not official legal advice. Disclaimer. But, a lot of times with malpractice type things, there's the question of, did this provider do what a reasonable and prudent dentist would do? Well, with these kind of guidances and all this information, if you're doing the things that, it says you should do, I think that's your defense. It is the standard of care to provide dental care to pregnant women. And I think you've got a lot of very official documents to lean on, not just you saying, well, I read somewhere it was okay. I mean, you've got things you can point to that, I did what was appropriate care based on research and science for this pregnant patient.
Thank you so much.
See, Patrick, you chatted a question. Do you mind unmuting and asking your question to the learning community?
That's awful, Patrick. You were trying to just type it, and she's calling you out and making you say it.
Okay, he may be shy. Those who are reading it says, I work for a clinic that has OB/GYN care, and so we generally get the clearance from the doc in writing from dental care. However, for a dentist who doesn't have that access, do you suggest getting written clearance for meds and anesthesia, et cetera, or feel comfortable based on what we've learned today?
Based on what we've learned today, you can provide dental care to that patient. Don't go off and do IV anesthesia, the things that it says to watch out for, but your basic dental care you can do. And there's a disconnect out there that we've got to work on. A lot of prenatal providers are like, yeah, they can get dental care, and they don't necessarily realize there's really a need to provide like a referral form, a consent saying that these things are okay. But of course, we on the dental side, we really feel far more comfortable having something saying that provider, says it's okay, they're cleared. And that's just something we'll have to work on. I think there's absolutely nothing wrong with wanting to have that clearance. But that said, if you want to get that before you do the fillings, fine. But when they're there for those x-rays and that cleaning, do those things. All of this is safe, and you don't have to have that clearance. But if you feel like you need it, then ask them for it.
there's another question in the chat. Do I call you out or do I read it? Would you like to unmute? Is it Grisha? What do you think about improving the response rate to the state and national survey in the pregnant women? The PRAMS survey response rate for Texas is lower than any other states.
It's a big problem overall, getting people to respond to surveys, and it seems to be getting worse. With PRAMS, they do collect enough data that it's a representative sample, meaning we can say 33% of pregnant women in Texas did this instead of 33% of the women who answered the survey, which is kind of what I had to do with the dentist stuff. You know, X% of the dentists who answered it, but that doesn't reflect all of Texas. PRAMS still does, thankfully, reflect all of Texas. How to get higher response rates, I don't know. It's a big question that everybody conducting surveys is facing. And for the dentist in the audience, next time we submit one of these surveys, please answer it, because it's really important for us to have this information. And we will hit all of you up with the survey again at some point, so please respond.
Very good. Any other questions in the community? Well, again, Dr. Stokley, we appreciate your time and spending with us. Your presentation was well informed, and we got a lot of information out of it. So thank you for all the resources on it as well. We will make sure this community receives those as well. So at this time, we will move over to the case study. Dr. Franklin, when you are ready, please begin.
All right, I'm ready. Good morning again, everybody. So after our wonderful presentation from Dr. Stokley, at this point, you should feel at least a little bit more comfortable seeing a pregnant patient. So I'm going to present a case to you that will give you the opportunity to apply some of the things that we just learned as far as treating a patient that might come into your facility. So this patient presented to me actually about 2 weeks ago. She's a 32-year-old, of course, female. She is insured under commercial health insurance on the Humana health plan. She does have stable housing and reports a household size of 1 person, but her available annual household income is unknown. And we can keep going down the form. We're going to come back to some questions that allow us to think a little bit more about this patient later. When she presented to me, she has been coming to the clinics in and out, not consistently since about 2019. So on this most recent visit, she reported no pain. She was there because she was told by her OBGYN that she needed to get a cleaning done because she was pregnant. So the kind of funny situation about this particular patient is she came in 2019 for the exact same reason, because her doctor told her to come. So when she presented about 2 weeks ago, she was again sent by her doctor due to concerns of poor oral hygiene and decayed teeth. The patient is currently in her 3rd trimester of her 2nd pregnancy. I think she was about 34 weeks at the time. Her medical history, she does have sickle cell disease. Surgery history, she's had kidney surgeries, gallbladder removal, spleen removal, and an appendectomy. Current medications include an aspirin as a preventive for heart attack, heparin to help control her sickle cell disease, and both of those are anticoagulants. Pay attention to that, you might need it later. So nutritional supplements are that she's currently on a folic acid and a prenatal vitamin. And whether she's had an adverse effect to local anesthesia, no, I've treated this patient before a couple times. She has had no adverse effects. So with our ASA classification, being pregnant automatically puts you in an ASA 2 classification, and that's with a normal pregnancy. So since this patient has additional medical complications on top of her pregnancy, and they are systemic diseases, that puts her in an ASA classification of 3. So we do need to manage her on a pregnant complication aspect as far as her medical history as well. Comorbidities that exist with this patient include kidney disease, and her body weight was reported about 143 pounds at the time. Blood pressure taken the day of visit was 116/82. Pulse was 94. We do not take respiration measurements at my clinic, and it wasn't really necessary for this patient either. Again, she's 34 weeks pregnant, no history of illicit drug use, and no past history of intravenous drug use either. No tobacco, no alcohol reported. It had been about 5 months since her last dental visit. She did have treatment left undone at the time that she stopped coming in. So that's going to be a patient consistency issue of getting them to come in when they're supposed to come in. When you work in community health, you will, or if you decide to, you will find that that is an issue. And so we have to work a little bit harder to get our patients to come back and see us when they're supposed to. So as far as her current dental condition, existing, missing, or extracted teeth that she has are number 5, 12 through 14, number 21, and 28. She does have 2 gold crowns on 7 and 10. No endodontically treated teeth. She has no aesthetic concerns, and she has no history of prior removable prosthesis. Head and neck exam and extraoral, intraoral, no significant findings were there. Her TMD exam was within normal limits, so no popping, clicking, no complaints of pain or anything like that. As far as her oral cancer risk, she was assessed at a lower risk because she does not participate in tobacco use or alcohol use either. Her caries risk is high, and her periodontal disease risk is moderate. I would say moderate to high. She does have a hygiene issue that could be improved, so we're working with her on that. As far as her race, she is African American, not Hispanic, and we can go a little bit lower down the page. As far as her periodontal presentation, the color of her gingiva is pink with red marbled brown areas. The contour is rounded. She has a smooth consistency of the tissue. White wings were taken on the 7th, and a pan was taken on back in 2019. We do not do plaque indices or calculus indices either. And her occlusion was assessed as a class 1. So my proposed treatment plan for this patient, when she came in, we did go ahead and clean her since it had been so long since we've seen her. We try to take advantage of when we have our patients in the clinic and do what we can for them while we have them here. So we did do a prophy on her and placed her on a 6-month reevaluation for perio and caries, encouraged her to continue her use of fluoridated toothpaste, and gave her some Act mouth rinse as well to help her with that. And so the proposed treatment, when I can get her to come back, she was supposed to come see me Tuesday, but she did not show up. So when I finally get her to come back, we're going to do phase 1 extractions, which is the patient's preference. We talked about her restorations that she needed, but she prefers to get removed before she does anything else, because in her mind, that's what's important. And usually with our patients, if that's what they're willing to come back for, we'll go ahead and do that until we earn their trust and get them to come back for what we're recommending. So phase 1 is extraction. Her phase 2 will be direct restorations. And she does not have a phase 3 at this time because, like I said, we're just trying to trust the patient. So we just need her to come back, period, at this point. And then once we are used to coming back, then we're going to go for phase 3 treatment. So proposed referrals included an oral and cross referral eventually. This patient was supposed to come to see me for extractions, and I'm more than likely going to refer her for anything that we can't do in the clinic. But
Are others having some trouble hearing Dr. Franklin?
I think she dropped.
Dr. Franklin, I chatted you, and I think if you're able to jump over to your phone, we talked about some contingency plans, or cut your video. In the meantime, I can navigate back up to those questions, and we can, as a group, be checking those out.
I'm back. Can y'all hear me?
Yes.
I think we're at the end anyway, so yeah, so we can go back up to those questions. Okay, so after discussing this patient, we do have a couple of questions that we would love for the audience to engage with us. And if you treat pregnant patients, let us know a little bit more about what you would do in these situations. If you do not, the questions is, would you request any communication from a patient's medical provider? And if you would, what information would you like to provide?
Dr. Franklin, if you don't mind, I'm going to read the questions for you for the audience.
Thank
Number
you.
one, you're welcome. Would you request any communication from the patient's medical providers? What information would you like provided, if so? 2, what considerations should be made in the selection of prescribed medications for this patient? And 3, what oral health hygiene education may be provided for this patient? So let's go ahead and open to the community, and we can get some suggestions on possible recommendations. I could open to the...
Cassie, I don't know who has those, but I sent in some illustrative material as well that might help the audience get a feel for it. Includes her x-rays, so they can see that. I don't know who would be able to pull it up.
Yes, Andrew is pulling it up for us.
So they can, look at that really quickly.
Wonderful.
So that it's not just words.
Do you see those there, Dr. Franklin?
Yes.
Okay, go ahead.
So you can go to the next slide. So this is the medical consent or the referral that was, or clearance, I should say, is a form of clearance that was sent with the patient, but you are able to read it, and being a dentist or a clinician, you can form your own opinions about the information sit with the patient. And there is going to be a follow-up question about what type of information you would like to see. Me personally, I appreciate the nice, lovely letter that the doctor sent over, but it's really not giving me any information that I would need about the patient. So it's not telling me whether there's any pregnancy complications. There's nothing about whether the patient has presented consistently for medical visits. It's pretty much telling us things that we already know as a dentist. So when you decide to request a medical clearance from your physician, you might need to consider, you might have to ask specific questions because they might not know to tell you. So we go to the next slide, please.
And Dr. Franklin, to maybe support your audio connection, if you turn off your video, it may sound better. We love seeing your face though.
Does this help a little bit? Or so far?
So far.
Okay, so this is just her pan that we took in 2019. So you can see a couple of broken teeth are present, and she does have a few cavities that we'll be able to see a little bit better in the bite wings on the next slide. So we can go to the next slide. And this is just of the experts that we've taken on her, the most recent bite wings, and also the PAs that we took in 2020. She does have some very large cavities, especially in the lower left. So we're going to manage, like I said, she would like to have broken teeth removed first, and then we're going to go to fixing cavities. So this is just to give you a better picture of what this patient presents like. And we can go to the next slide. So this is her treatment plan, phase 1 and phase 2 treatment illustrated here. So extractions, direct restorations, no prosthesis at this time. We can go to the next slide.
We might have lost.
This here as a reminder about ASA classification. If you ever need to read a book or a quick Google search, ASA classification of statute will take you to this chart. And in the far right, it gives you classifications based on the health status of your pregnant patient. Like we were talking about medical clearance, to kind of give you an idea as well on the questions that you might need to ask specific from physicians. You might need to know for your patient. And I think that might be the last slide. Go more.
Okay. We already have a question in the chat. Rick, do you want to unmute and ask? I will go ahead and ask for you. She is, okay, no worry, Rick. She is approximately 6 weeks out from delivery. Are you planning on doing all of the treatment prior to delivery?
The case really depends on if she shows up or not. I would not be opposed to doing the treatment prior to never what to treat her. There's no reason why I couldn't do any or all of this treatment while she's pregnant, but it really just shows.
Dr. Franklin, I'm going to put in the chat some instructions for just calling in by phone. I think that might be best at this point. It's the audio sounding a little choppy. I think you can stay on until you call in, though.
Okay.
Rick, she answered your question for you. And then there was a question a few minutes back from Jay Harris. It says, I'm curious about the heparin and aspirin used together. Dr. Google reports this is from the Mayo Clinic. Do you take aspirin, ibuprofen, and other anti-inflammatory medicines while you're using heparin? I hope I'm saying that right. Many non-prescriptions, over-the-counter OTC medications, and some of the medications contains these ingredients. This is from February 2021.
Right, and I agree. I don't know if you can will hear everything that I am saying, but that's the type of discussion you have with the treating physician, because that is who has placed the patient on this, program. So I never or rarely change a patient's instructions from their medical provider. I will ask if I'm, concerned about it. I will ask. It's kind of because you don't really have that authority. We are dentists and we do know medicine, but there has to be some reason that the doctor has this patient placed on both. So that's the type of question that you should ask the medical provider.
Mm-hmm. Thank you. And open it up to the learning community here. What are people's impressions about this case? What would they do? Or questions they may have, or regarding medication, or
Welcome to
hygiene health. I think one of the questions on what would we do regarding her hygiene health, or what would you do? I'm not a dentist.
What do we think about when we've got patients and then there's cultural issues to consider as well? There's all of the thoughts of like, I remember hearing patients, it's like, oh yes, every time I'm pregnant, I lose a tooth. Or, how do we work with patients that come in with these thoughts that have been passed on from generation to generation? What does the audience think?
Magda, I'll say something if that's okay.
Yes.
With our work that we've been doing with home visitors and working with them to provide oral health education to their clients, this is something we've had to deal with. And one of the most important things is you can't insult what their mother and grandmother told them, right? You have to be very careful about that. This family wisdom that's handed down, whether it's accurate or not. And be kind in the way you say, well, yeah, we do hear that a lot. But in fact, you know, with just taking care of your teeth and stuff, there's no reason to lose any teeth with baby. You know, but be respectful. And something we've run into also is some of these younger women kind of get torn between two worlds. They're listening to the information we're providing them and believing it, and their grandmothers at home say, no, don't do that. And so they're having to, you know, kind of walk between these two worlds because grandma's getting pretty insulted. And so, again, we have to help them to understand maybe even how to communicate to grandma and say, well, but grandma, we know so much more now than when mama was a baby. And like I said, just be really kind, and you can't put anybody on the defensive. You'll never win that way.
Does anyone else have anything to share where maybe they've encountered this with a patient themselves?
Magda, I see something in the chat. So Fahad Arshaf, I think this is what the patient said. When I was pregnant, I lost calcium and that affected my teeth. So this is probably one example of how they think it works and affects them, their teeth when they're pregnant.
Right, so the loss of calcium. Thank you, Fahad, for sharing. Anyone else? I know that Maria had a question. Would you like to ask your question, Maria?
Absolutely. Thank you so much for the presentations. They were wonderful. I was just wondering because consistency in meeting her appointments seems to be a concern with this patient. Is that a common thing that happens among pregnant women? That's kind of a separate question. But also, I wonder if any motivational interviewing techniques have been used with this patient to address her fears, or if there were any, Dr. Stokley, Dr. Franklin, that you have seen in your vast experience, just some things that help, catchphrases, or perhaps flowcharts of things that maybe can be used to motivate them to keep up with appointments and oral hygiene, or anything of that sort.
I think you're on mute, Dr. Franklin. *6 on the phone.
I'm trying to talk on the phone, but I don't think it's picking up.
We can hear you right now.
Okay, so I can kind of answer that question as long as everybody can hear me okay for this particular patient. So I have treated her in the past. I think it's just going to have to be an issue of building up a desire to come back. I treat her mom as well. So I know this patient does have the added factor of mom being at home telling her one thing, and I'm in the clinic telling her another. Well, who has the most time with her? Mom. So when I do see patients like this that I know are not going to really come back, I try to do everything or convince them to come back and let me do everything that we need to do to get them in a state of better health. Sometimes it does help if you make them realize how much of an impact it can have on their child. Sometimes they come back, sometimes they won't. I've had pregnant patients who still smoke, but they want to know what's in the anesthetic I'm about to give them. So it's really about what they feel is important and the rapport that you build with your patients. So every patient is going to be different pretty much.
Thank you so much, Dr. Franklin.
I do want to make sure we answer your first question or get some guidance. Would you request any communication from the patient's medical provider? Now, is there a way not to request information for the provider? Is that just an automatic, content information when you're treating a patient? What's their past history, comorbidities, anything else that they need to know before treating a pregnant patient? Is there any guidance we should, the fellows should know about requesting medical information?
So me personally, I just think of it as your pregnant patient is still a patient first. So any medical conditions that you would request or be concerned about for a regular patient, you still need to take those into consideration with your pregnant patients. Now you do have the added, I guess, bonus of it being a pregnant patient. So speaking for just pregnancy, I would like to know, of course, about any gestational diabetes, high blood pressure that has just been onset during the pregnancy, morning sickness or any nausea at all, because I have had a pregnant patient throw up on me. So I like to know that just for personal reasons now, whether the patient can breathe okay when they're reclined. So just things like that. You kind of have to be thinking in your head of what your the type of things that you might want to know about in advance before you get started.
Very good.
Thank you, Dr. Franklin. Those were really good ideas for us to think about, especially the morning sickness. And even when you've had a patient that's been a patient of record and has had no history of high blood pressure or hypertension, right? And now you want to know if that continues throughout their pregnancy. So those are good observations to bring out to us. Thank you.
Dr. Stokley, did you have any guidance that might be provided when communicating with patient providers? Your perspective?
I would say, if in doubt, communicate with the medical provider. In any circumstance, if you feel like you need that extra assurance, you don't feel like you're not really sure that the pregnant patient is kind of giving you all the information you feel like you need, reach out. It's never a wrong thing to do, to communicate with other professionals. And we seem to do that so much more easily with our orthodontist colleagues or prosthodontists. When we share a patient, this obstetrician is our colleague. So reach out and communicate and get the information you need so that you can practice comfortably.
Thank you. Brittany, would you like to unmute and ask your question to the learning community?
It wasn't really a question, just something to add to that conversation. If you're asking them about nausea, morning sickness, sometimes it's worse for people earlier in the day or later in the day. If you know that ahead of time, you can kind of schedule around that, because someone who wakes up feeling nauseous doesn't want to go sit in your chair and have you dig around in their mouth all morning. So you can kind of schedule around that to hopefully get them to be able to show up and feel better at their appointment.
Do you find that when you have a woman who's pregnant, that being pregnant and now knowing that she's also going to be responsible for caring for the oral health care of that child is a motivating factor for her to improve her oral health or to learn more about how to care for her baby as well once the child is born and has teeth or even gums that we know we need to wipe as well? Any thoughts on that from everybody or anybody on the phone or in the meeting?
Don't be shy. We are all learning together here. No comments.
I can just share a brief comment that in my experience, it is helpful to say to the mother to make that connection of what she's doing can impact her baby. And so in my experience, when I was still in the clinics daily, I definitely used that as motivation, just letting her know that she's doing something for her child that's not even here yet by taking care of her own oral health. I think it does matter. And the only other thing that I thought to mention was I actually did a presentation several years ago on perinatal oral health, and there was an article that I found from a physician who was a little bit frustrated with dentists because she wanted everyone to know that pregnancy in itself is not an illness. And so she said, if she gets another routine, like, please give me medical clearance because I want to work on a pregnant patient, request from a dentist, she sent out like this letter that was addressed to all dentists. So I really appreciate the fact that you guys are, having this balanced conversation where you first acknowledge, that, okay, the person's pregnant, it's a condition, it's not an automatic illness. If they have systemic problems like someone else, then, address those things if necessary. But if they're totally healthy and they are pregnant, that you may not need to send this letter for every single pregnant patient that you see. And so there's physicians that definitely feel they are aware of the guidelines. And so they want us to, review the guidelines and act accordingly. So great presentation.
Wonderful. Any other comments from our community? Follow-up questions that you may have regarding the case?
Hello, can you hear me?
Yes, David, thank you.
Yeah. Well, I thought maybe I would contribute.
Awesome.
My thoughts were, I had a couple of thoughts. One was with regard to Dr. Franklin's case presentation and her patient and having the concerns about influencing her, and that her mother or some other factors might be involved with providing other information to her, wondering about inviting the mother to come in for the appointments. I wonder what Dr. Franklin would think about that.
So that's a good thought. I am hearing an echo first of all. So I do see mom. So I have a good idea of how her mannerisms are. And she has not actually presented with the patient to an appointment. Great invitation to extend to her. I need to consider that.
Well, it's not easy. You have your hands full trying to have an influence when mom may have a stronger influence. So I can see the challenge there, and I know that Magda knows about that. So it's always, I can't remember who was saying it. I think Dr. Franklin, it's individual with each patient trying to understand what is their motivation and who are their influences. And each one is a little different, but trying to affect some information or behavior changes, it is difficult. It's a continual challenge. And when there are other influences, if there's any way you can tap into those other influences or bring them in, that just a thought crossed my mind. Maybe that would, help to navigate that communication. So it's an ongoing challenge in that way. Not necessarily easy to bring in someone else either. What do you think?
I actually like that idea. I do tend to let my patients have one person that come back with them. So I might have to ask this patient if she would like to bring her mother next time. That might work.
That sounds interesting though, doesn't it? Mom may be you want to be careful mom doesn't start influencing you.
When I know each other, I knew mom first, so I don't think that'll happen.
Oh, you guys sound like you're pretty well connected.
Good.
I think it brings up the thought that we need to sometimes be creative as to how we can reach our patients and do that motivational interviewing or that motivation of behavioral changes and just increasing the knowledge and making them and helping them to feel safe. So it just means that we've got to be creative sometimes. Thanks, David.
Thank you, Magda, for that final comment. Unfortunately, we're at the hour, but I like that description of, kind of almost a community work of trying to get everyone to the table and understanding what's the best practices for our pregnant patients. So I want to thank Dr. Stokley and Dr. Franklin for presenting today and taking your time to be with the community and join our DENT ECHO. So thank you so very much. We look forward to seeing everyone next month. We will have our third ECHO on July 15th. You will receive email regarding CMEs, and you will get information on registering for July's ECHO. So until then, everyone stay safe and healthy and happy, and we will see you next time. Thank you so much.
Dr. Stokley and Dr. Franklin.
My pleasure. Hi, everybody.